Hey guys, and welcome back to another episode of Surviving Out of Spite. My name is Samantha Sauer, and I am your host. Living with gastroparesis is so much more than symptoms on a chart. It's the constant food anxiety, the endless medication shuffle, and the search for a doctor who actually gets it. In this episode, I sit down with Dr. Zach Spiritos, a neuro-GI, to unpack the brain-gut connection, why patient-centered care matters, and how we can push for the treatment approaches that go beyond checklists and truly support the person behind the diagnosis. Stay tuned. All right, so thank you for being here today. I'll give you a little time to introduce yourself for the community members who aren't familiar with you and your Instagram presence yet.
My name is Zach Spiritos. I'm a physician. I'm a neurogastroenterologist, which means that we pay attention to the tube that connects the mouth to the rectum, but we also pay attention to the connections between the GI tract and the brain and the central nervous system. I trained at Duke University, and then I was at a UNC-based practice for a couple of years, and then I left to start my own practice, where we deal with complex GI conditions like gastroparesis and cyclic vomiting syndrome. And we also treat dysautonomia, including conditions called like POTS. We also treat mast cell activation syndrome and recognize the challenges and complications of living with hypermobility, like Ehlers-Danlos and hypermobility spectrum disorder.
So, from my own experience with GI doctors, they don't have any or very limited experience with all the disease states that you mentioned. What made you choose this particular subset of GI patients over just regular gastroenterology?
It's so fun. It's just a blast. When you talk about neurogastroenterology, there's so many different inputs and there are very varied variables. A lot of different variables that affect how our GI system moves and how we perceive it, from our sleep to our diet to stress to familiar relations to medications. So you get a real opportunity to kind of understand your patient and work with them together on finding strategies to improve not only their digestive health, but their overall health and well-being as well.
Now, I know I appreciate that sentiment, and all the patients that listen to us probably do too, because I know from, again, my experience and a lot of the patient experiences that we hear about, you don't really get that holistic focus, right? You kind of go in, you talk about symptoms, and we were just chatting earlier about medications. You're kind of, the offerings that you get at a normal appointment or with a very general GI doctor isn't what you are offering and what you are talking about, which is really interesting. I didn't even know neuro-GI was a thing until a couple years ago, and I've had gastroparesis for over a decade, and I didn't know that was even a thing, that there was somebody that specialized in additional pieces of the disease that maybe could have treated me differently and maybe helped some of my symptoms earlier in the disease development for myself. So it's really just cool that this exists.
Yeah, there are a couple other crazy people like me out there. I'd like to explore this space. It's very rewarding, definitely fills my cup up, and I love the patients that I get to hang out with all day.
Yeah, and we're very complicated, very complicated. I know that's kept me out of some doctors' offices because they don't want to treat me, and you're just like, here, come on in, we'll take you. Which for a lot of the patients that's a good feeling, to not want to be turned away because you're just too complicated.
Yeah, it's I try to give people the benefit of the doubt, and when people feel there are obviously physicians that say some wild and crazy things that are completely inappropriate, but I also think that they're put in a compromised position at times. They're just not enough time. I was just in a recent center where we spent 15 to 30 minutes with patients. And when you have someone with gastroparesis or motility conditions, it's not something you can wrap up in that amount of time. So technically you have 30 minutes, but people check in, they get their vitals checked, right? They triage, and when it's all said and done, you really have like 10 minutes with a provider. And then the provider's thinking about the documentation and all the biopsy results that they have to get back to and the mailbox. And it's just, you're just not in a position to succeed. And so I think, there are times where, a physician may just, unintentionally, or I don't know, maybe hopefully not intentionally, minimize a patient's symptoms. But I think these are very complex cases, and you really need a lot of time to sift through a patient's history about how they got here, what makes them feel better, what makes them feel worse, their diet, their sleep, everything that really affects motility, and how people feel it and sense it. And in that truncated, abbreviated visit, there's just insufficient amount of time for providers to get through. So I think, everybody's kind of frustrated by the situation, but especially,
Definitely.
and the patient suffers, which is, there's no excuse for that, obviously, but it's challenging.
Yeah, it definitely is. And I've said before, when I've seen, my doctors are overwhelmed and they're burnout and they're dealing with so much, like, I understand that, and everything that you're saying that we don't see as patients that the doctors are dealing with, including their other patients, right? Like, I understand that logically. Emotionally, it's hard to understand that when you're only getting those 10 minutes that you're talking about, and you've got this laundry list of things that you need to really sit down and discuss each of those. And maybe you get to one or two, or it goes so fast that you don't even remember what happened during that appointment. They blow in, they blow out, and you're sitting there and you're like, I'll see you in 6 months. And like, but what? Nothing happened. I didn't get anywhere. I didn't even get to ask you any of the questions I wanted to ask you. And if you look okay, sometimes, at least for me in the last few years, when I'm starting to complain about something, or I might want to say, hey, this is not going that well, I kind of get like that. Yep, I hear you. Okay, so do we want to just change something, or are you good? All right, I'll see you in a couple months, and then leave. I'm like, but okay.
Yeah. And the compound things, and we can certainly talk about this, is the gastric emptying test is not exactly the most perfect test out there. It's kind of the best that we got right now. You can have someone with no delay but actually have gastroparesis,
Yes.
or mild delay and have tremendous amount of symptoms. And so they look at this gastric emptying study, they go, oh, it's a little bit delayed, like maybe just eat smaller meals, but it's more profound than that. There's people are riddled with nausea and getting full early and vomiting and losing weight. But so there's that discordancy as well. Not only do people look healthy, but their tests don't really, there's not an endoscopy with horrible ulcerations and blood everywhere, which like, oh my God, that person's sick. But this person, these people with motility conditions like gastroparesis, are equally, if not more affected, have really affected quality of lives by these conditions. And part of it's because we don't understand it very well. Like we understand ulcers, things that we can like look at and biopsy, like that we understand. Cancer, Crohn's disease, ulcerative colitis, which is fraught with challenges as well. Like I'm not minimizing that by any means. But,
Sure.
When there's motility disorders, there's not a kind of a picture that you can point to, like, that's how bad I feel. And people,
I wish.
said, look okay. It's not, it's maybe try meditating. They'll offer some
Yoga.
Yoga.
Which not that yoga doesn't help, but again, sometimes those types of maybe meaningful suggestions can often feel dismissive, because it kind of feels like you're getting this suggestion just based on a quick thought, and not really somebody sitting down with you and discussing, like, how did this affect your life? Or because it's not in your blood work, or like you said, it's not tangible, right? The symptoms are not always easily seen, heard, or anything like that. And you're just sitting here like, I'm trying to tell you how I feel, and it's often unintentionally dismissed. But, from talking to you and everything that you've shared on social media and that patient experience, it seems like you have a better understanding of that patient experience. And having that time with your patients, I think probably helps you understand that. It fosters trust with the patients. And, sometimes, as we've seen some of your reels, they make us giggle too, because the understanding is the often like not talked about kind of like not always, dinner table conversation kind of symptoms, but they're the things that people need to talk about. They're the things that you're like, oh, I see this person talking about this, or this doctor brought this up. Like, he understands what I'm talking about. So it just kind of leaves a good impression that you really do understand the patients, or trying to, which is great.
Yeah, I mean, it's my pleasure, and I love doing it, and it's there's such discrepancy between what you learn in fellowship and training and then what you get out and see. And, I remember in my first couple weeks, the months as an attending on my own, and people would be like, I'm really bloated. What's this about? But we didn't really learn how to treat bloating. Like it wasn't part of our curriculum. We learned about cancer and polyps and, Crohn's disease and ulcerative colitis and eosinophilic esophagitis. But people care a lot. Like, why is there a bunch of mucus in my stool? Or, why do I have to sit in this kind of weird position to poop? And it's like, so like, it's getting curious about these questions and then understanding like how things affect each other. And then just apply that same curiosity to gastroparesis. Like, why does someone feel awful or why does someone feel great when they take this medication, but someone with the same diagnosis feels terrible on the same medication? And why does one intervention work really well for someone, but not for the other one? And then you realize it just gets infinitely complex. And that's part of the reason why, there's not a universal kind of protocol for gastroparesis. It's because everybody's different and everybody's gastroparesis is unique to them. And everything from how their stomach moves or doesn't move to their symptom profile. And it's just, it takes time to understand, how the patient got to this position, what makes them better, what makes them worse, and then trying to figure out the right buttons to press. And it's a shared decision, right? It's something like, take this medication, eat this food, right? It's like, here's kind of what I think is going on. Okay. Now, how does this sound to you? Does this make sense to you? And if it does, then like maybe it's working a plan together to get you feeling better. And what happens if my plan doesn't work? Which happens, right? Like there's some of this is not, this is not a dermatitis where it's like, okay, I'm going to give you some antibiotics, you're going to feel better. Like some of this is trial and error and feel, right? And so, we'll try something, but like we need to counter. So what happens if this doesn't work? And so that's, you have to take the evidence, which is okay, with also the patient experience and marry the two to try to find the best plan for people. And
Yeah, that trial and error can be really scary. I know in a previous episode that we had talked about with food in particular and trial and error, because that goes for medication too, with that same fear around, is this going to make me feel better? Is it going to make me feel worse? Or when might it make me feel better? Like, you have the understanding to say, okay, well, if this doesn't work, let me know, we'll move on to a plan B and kind of go from there. But when you're in a situation with a patient who either has a fear around that food or trying new foods because food makes you feel like crap, or every other medication that maybe you've tried has left you feeling worse or had side effects or just did nothing at all, how might you work that patient through like that fear? Because I imagine you've had a handful of those patients that come through. I know I have felt that way. Sometimes food is just getting through that. You trial and error. It's terrifying, but it's a very necessary evil in treating this disease because, as you said, one size does not fit all. So you have to figure out what works, and that's terrifying.
Yeah, it's a really good question, and it's a tough situation. So let's talk about food first and the fear of food. So it starts with education from my perspective. So trying to talk to people about why food is uncomfortable and why it hurts. And so you can equip patients with the knowledge to pick foods that may agree with their body. So taking what I think about their pathophysiology. So if you have gastroparesis, right, and I use this blender analogy, right? And so the stomach is a glorified blender. And in gastroparesis, that blade is just a little bit dull, right? And so food just kind of sits there. And so the blade is kind of doing this and it's just not rotating very well. And the edges are dulled. So we talk about, like, imagine putting a carrot in there. Like, that's not going to go very well. So how do we get fiber in there? Like, imagine, like, so what happens if you put, applesauce in there or carrot juice in there? Like, that's, so trying to create that analogy, but also like and we know what diet works well in gastroparesis, which is kind of a low residue, low particle diet, which is just kind of like low fiber, low fat, all the fibrous stuff should be blenderized, no seeds, no skins. But some people feel terrible on some of the things that I'm recommending. So you have to say, okay, this is what I know about gastroparesis. Now tell me what you feel, and let's marry the two things and see if we can find a balance there. I will also say I'm not a dietitian, right? I think a lot about food, but I'm not formally trained there. So I love working with my GI dietitian to help us out. And then there's the anxiety around it, okay? And that's where sometimes, if we find it to be appropriate for that patient, we loop in a GI psychologist to work on cognitive behavioral therapy and kind of reassessing our thoughts and fears around food and challenging them. Like, if I get a little pain, is this going to ruin my day, or is this something that I can work through? And there's a lot of different kind of coping strategies that one could implement. And so it's identifying like the needs and the wants of some patients. And some people are like, I don't want to see a therapist. I was like, great, we don't have to. But there's different options. And you kind of have to just assess everybody's unique relationship to food and try to patch up whatever holes or anxieties are there. Medications is a little different. Most medications that I find people are fearful of are the neuromodulators.
Okay. Makes sense.
So sometimes we use antidepressants in gastroparesis. Not that they help with the motility at all, but they help with the sensation part of things. So gastroparesis shouldn't hurt. It should feel like like you're full too early and you get nauseous. But the pain component is part of kind of dysautonomia issues with the nervous system, but it's not the motility part, but the sensory part is also a little bit thrown off.
Yeah.
And so sometimes, and we don't use it for everybody, but it's an option, is to use neuromodulators, which are kind of traditionally antidepressants. And we use, SNRIs like Cymbalta or TCAs, like or tricyclic antidepressants, and we use them at very, very, very low doses. So not useful necessarily for depression. And they can kind of turn down those pain signals in the central nervous system that are being sent from the stomach. And that's a touchy situation because some people are like, I'm not depressed. I'm not saying you're depressed. This is a tool that we can use. It's not blank. I don't think we put it in the water supply or give it to everybody. It's for a very specific person who has a lot of pain forward symptoms. People get really worried about those and the side effects. And
I can see why.
And so, I talk to my patients every week and say, like, please let me know how things are going. I also say that if you experience a little side effect, for like fatigue early on, that means the medication is working, right? Like it's changing that chemistry. If that fatigue is profound, where you can't go to work, like, okay, we're not using it. But if you have a little fatigue or a little bit like, I feel a little off, well, that means it's working. Is it weird, different, or is it detrimental? Because weird and different, we can that's something that we can maybe live with if it's offsetting your pain, right? If that balance is one that we find is reasonable for your care, that the benefits outweigh the risks, so to speak.
Sure.
But yeah, so it's tough, right? So it's all on an individual basis and understanding why someone is fearful of a specific thing, and then trying to help them understand why these things happen. So when something happens in the body, like, this is what that is, right? I don't have to, when we get a sensation, and part of cognitive behavioral therapy is assessing the way we think and feel about certain sensations in our bodies. So when we get a sensation, it's like, oh my gosh, like something's wrong, or this is the medication working. Right. Yeah. So I think there's different ways to think about it. And I'm not trying to trick people, but it's like if you go into a medication thinking it's not going to work, it's not going to work.
Yeah.
Right. But if you go into with a medication thinking like this may work, then it may work. It's mindset is a part of it as well. And I'm not tricking people. I'm being very honest with people. I'm like, this is exactly what I'm doing. I'm telling you so you know exactly what to expect, so you're not surprised by any of this. And that's, I do my best, but it's not a perfect science.
Yeah, that's a really interesting approach. And I know the dietitian that I had talked with about the trial and error, she had a very similar idea about addressing that with somebody who has a fear around food. And I like that the approach is education and conversation and really just trying to explain what's happening or what might happen to somebody, kind of taking the emotion out of it, right? It's addressing the emotion. It's addressing that this is there, this is real. You understand the anxiety, you understand that this is scary, and validating that for the patient. But then trying to walk them through from A to B, like what's actually happening, what could happen, and, just taking that a step further to really say, like, you're okay. This is just what's happening. This is what could happen. Let's just talk about it. This is why I'm giving you this. And I know from personal experience that it's scary to tell someone that you have a fear for something, right? That you're scared of something, because the responses can be very up in the air. You're not really sure how the person's going to react to you saying that you have a fear about something. So I like that approach. And I'm glad that more people that I've had conversations with about this type of topic or this type of thing that happens with this particular subset of GI patients, that you're taking that approach, because I think people are starting to see how, like you said, if you believe something's not going to work, it's not going to work, right? So if you are afraid of something and if you think it's going to hurt you, it's going to hurt you no matter what happens, because of the, connection between how our mindset, it really affects the physical outcome of our disease state as well. I like that.
Yeah, no, and I think I let patients know this is a partnership. Like, we're working together, and I'm not saying like, okay, take this and I'll see you 3 months.
6 months.
It's like we are like in lockstep, and a lot of these plans are predicated on really good communication between us. And, if you feel like something is scary and you don't want to do it, we won't have to do it. Like, there's other ways to go about things. And so I usually try to present a menu to people. Like, we can do all of these things. This is how I feel about each one of these options. Here's the cost associated with it. Here's the risks, the benefits, and let's find, based on what your moral compass is, your finances, like, let's find the right thing for you.
Yeah, that's great. It's just really refreshing for me, I haven't been in this space as long as a lot of people have, but from where things were when I first got diagnosed to now, it's really great to see how some of the approaches and some of the things, or at least the conversations, are starting to change now, with doctors, patient to patient, or just the general consensus around the disease and how that can affect your life. And other than just, you can't eat, or you can eat less, or you have to eat differently. So it's just the conversations are, I think, finally starting to change, and more people are speaking up and saying the hard things out loud and really talking about that, and not letting just the typical assumptions of the disease kind of drive the conversation every time now, which is great.
Yeah, I agree.
Now, in your practice, since I know we talked a little bit about like the medications and diet and that type of treatment, do you do any of the more invasive treatments, not necessarily like testing with endoscopies, but any sort of like tube feeds or, TPN? I know that's not the invasive treatment per se, but, managing that is a little different than managing somebody on medication, or we talked about G-PACT and things like that. So where does I'll say the line for the treatment of what you guys can do in your current clinic fall?
Oh, I guess practically, so we're a telehealth group.
Mm-hmm.
I've put many people on tube feeds, but it always goes down to meeting people where they are. And so I had a young woman a couple weeks ago who has gastroparesis, and I think she also has something called mast cell activation syndrome, and it makes it really, really eat. And she was getting enough calories in. Her weight has been stable. And I was like, let's try some things, medications, diet changes, and let's see where we go. And she goes, I'd really like a feeding tube. And she has such a horrible time eating. It makes her feel so bad. Pain, nausea. She's like, I don't even want to deal with it. And so my answer is absolutely. Well, let's talk about like what that means, right? Mm-hmm. Like the risks and the benefits. And, I'm going to do a nasogastric tube first, or a nasojejunal tube first. There's going to be a tube in your nose, which is lovely as it sounds. And then if we're doing okay there, then we can consider doing a percutaneous tube through the stomach. And so if you're okay with all of this, then absolutely we can do that. Fortunately, I've made a lot of colleagues and friends throughout the area and multiple states. I know a lot of GI doctors and IR doctors that can help us out.
That's great.
So I just call a local IR group and we get an NJ tube placed, and we have a dietitian to work with the tube feeds. And then if we need to convert that to a percutaneous approach, we can talk to an endoscopist. And so everybody's willing to help. We just pick up the phone and call people. So I don't really, I certainly calorie count, weights, make sure they're, look at their biomarkers, their nutritional status, like their prealbumin, all those things will kind of factor into a decision of whether to use tube feeds or not, while we stabilize things. And sometimes we can't stabilize things. The gut is frozen and we can't do anything. But sometimes we can, and we can use medications, some more foundational and some more advanced, to work on motility and any comorbid dysautonomia and mast cell activation syndrome. So yeah, it can get really complicated, but it's always, again, it's patient first, and there's no algorithm here. It's talking to the patient about what they want, and if they really want a tube feed or really don't want a tube feed, then we'll talk about it, and I'll tell them about the risks and benefits. I'm not anybody's parent, I'm their friend, and I'm their guide, right? And I'm not gonna slap their wrist if they don't want to do something. Like, everybody's an adult. You can make your own decision for yourself. My job is to lay out all the decisions with you and support you every step of the way and be candid and open and honest with you and give you the best information that I have.
Yeah. No, just patient to doctor, I appreciate that. I think between GI and endocrine, I think I've gone through probably the most doctors trying to find like the right person to have a conversation, have a relationship with. And my area doesn't really have a ton of options, especially when you have hit a point where you're complicated, but like I'm stable, right? Like at this moment in this time in my life, I'm relatively stable because I've been through all the other stuff already. I went through all of that, the really tough trial and error. It might still come back. I never know, what the future holds, but kind of been through all of that already. And trying to find somebody to listen like that, to have those conversations and to work with you is just difficult to find. And I think the more complicated you are, as you very well know, and things pop up, things don't look so easy. You can do all of the right things, you can follow all the rules, you can do the things that you think are going to work, and it didn't work. So then what do you do? And then, is the patient doing what you asked the patient to do, or is it just not working? So, and if you don't have that relationship with the patient for them to be honest with you, you're not going to be able to treat them to the best of your ability because you don't really know everything that's happening, because that trust hasn't been built, that openness hasn't happened yet. I know that's happened with other patients and other stories that I've heard over the years of just patients not feeling comfortable talking to their doctors about something. I think in the first or second episode, we openly talked about poop. People don't want to talk about it. People don't want to have those conversations because they're embarrassing and they're a little bit weird to have the conversation. But if you don't have that conversation, like that one thing that you need as the doctor to treat the patient could be missing. So if that bridge is not built in the beginning, or you're not working on building it, you can't do your job to the best of your ability, and the patient's not going to get the help that they need from you. So just... the dynamic is very interesting. The more conversations I have with people, the more I'm just like, it's such an interesting dynamic in this space, and such a not controversial, but really often misunderstood disease.
Oh yeah. Yeah. It's when a patient doesn't kind of do the plan, I often find that it's my fault. Like, it's always my fault. Like, I didn't do a good enough job of evaluating what they want to do and like what their goals are, right? And so you say, you've never met me before at all. Now in this 30 minutes, I want you to tell me everything about the most vulnerable pieces of your life. I'm going to tell you what to do. Like, it is a ridiculous thing. And it's it should happen in 2 hours. Like, you should probably go get a cup of coffee beforehand, before you talk about your bowel movements. I'm like, hey, I'm Zach. What's your poop look like on this chart over here? It's so weird. It's such a strange dynamic. Yes, I agree. And part of the job is trying to make people feel comfortable. I do love talking about poop. I welcome any. There was actually I did like an Instagram reel where I said, this is not, at the end of it, I said, this is not an invitation to send me pictures of your poop. And lo and behold, about 50 people on Instagram sent me pictures of their poop. And I was like, should I report? And I just wrote emojis with my hands clapping. I'm pro poop. You want to talk about it? Let's have at it. It's weird, but I'm not going to apologize for it.
That's amazing and terrible that people actually...
Social media is a weird space. I asked him. He knows coming.
It's funny though to bring that up because I had on our Instagram page, I don't remember when it was, but like to talk about when you finally, to give yourself a round of applause when your body finally does the thing that you've been asking it to do, right? To go poop, go to the bathroom, go do the thing. It's like round of applause, yay, you did it, and just thinking about something so natural, right? That should just happen.
Yeah.
It doesn't just happen. It requires a lot of thought, a lot of careful calculations to make that happen. And not something when initially you just are talking about gastroparesis, right? Like for somebody who knows that gastroparesis affects just the stomach, which is true. It's about stomach digestion and delayed in the stomach. But as I said to somebody earlier, my experience would differ from that definition. My experience would tell you that everything is slow, but it's just that's the patient experience and not necessarily what everything is, because it's all compounding and the GI system is complex. But never thought that I would A, be on the internet talking to somebody about my poop, or B, thinking about like why isn't this normal? And how is this normal? And what do we do about it? And how do you have that conversation with somebody when you're too embarrassed to talk about it, when that is the thing that you need to talk about? Because we all know we don't poop normal. If you don't eat normal, you don't poop normal. And if one part of your GI tract is slow, something else is probably slow too. And then it's going to be slow coming out. It's just how it is.
Mm-hmm. Yeah, I mean, there's really good data that shows that people with gastric dysmotility often have small bowel and colonic dysmotility as well. And so one of the first question I ask you when you have if you have like I have gastric nauseous, my first question isn't how often you vomit or how nauseous are you, it's how often you poop. Because if you don't clear up the backup on I-95, everything you can't get it under control if you're not pooping. But that's easier said than done. But you gotta start down by you gotta get the pipes clean before you can start thinking about this thing.
No, that's amazing and awkward all rolled into one. But I wish more people would ask those questions, because it usually is like, how nauseous are you and how often do you vomit? That's usually the first question.
I mean, they're relevant questions, but it's just like, you can't, it's anything that you do. Yeah, you got to focus on the poop. You gotta get it going.
So one of the things that I had thought about from our conversation and just some questions with patients who are kind of in that in-between state, you touched on it a little bit before about, patients who just need to maybe modify their diet a little bit, and, patients who really need some sort of intervention. But that in-between space of maybe somebody who you don't really want to send them for surgery, right? You don't want to give somebody something unnecessary. So how do you support patients who are stuck in the in-between, not sick enough for surgery, but too sick for the watch and wait?
Yeah, it's a great question. Again, there's no easy answer. And so, you gear, I guess, like broad strokes, you gear your approach to what symptoms the patient has. And so if it's pain, there's certain therapies for pain. If it's nausea, you really get into the nausea. If it's early satiety, then you get into that. And so diet is foundational. And then, we can use medications to kind of offer some relief in the meantime. Working with a dietitian, if we feel that there's kind of some central sensitization where there's a lot of comorbid anxiety, and I guess how could there not be, about your symptoms that are making the symptoms worse? Like, it is a vicious feedback, right? Your symptoms make you anxious, which then make your symptoms worse. Like that's this GI cycle, right? You have the gurgling in your belly and you're like, oh my God, what does this mean? And then that makes you go to the bathroom even faster. And so how do you break that cycle is there a psychotherapy component that we can utilize as well to help? It won't fix your gastroparesis, but it may help with kind of the the crescendo of symptoms, where you get a little symptom, it kind of spirals because you're so worried about it, you're so anxious about it, and how could you not be, of course? But so there's so many different, every patient is so incredibly different, and we do have a lot of different pharmacotherapies. They are far from perfect, but there's pretty good ones for nausea and some pretty good ones for pain, and so you tailor the therapies towards the person. And if we're kind of on this you're on your bike, but it's still pretty wobbly despite everything we do. We're doing the diet, we're doing the medications, and then, and if we feel that everything is truly due to gastroparesis and there's nothing else going on, right? There's no mast cell activation syndrome, there's no functional dyspepsia or anything like that, then we talk about more advanced therapies. But yeah, you do your best to avoid the advanced therapies because again, they sometimes they're fabulously for some people, but not so much for others. And we're still kind of in this infantile stage of identifying who's the best person for these advanced procedures, whether that's a stimulator or a pump.
Now, we were talking earlier, before we hopped on, about like the AGA guidelines and some of the, like I had mentioned for myself in the poem that's deemed experimental and, not something that is first line recommended, which even I would never say that would be like your first line recommendation, right? And you need to go to somebody who is experienced, which thankfully for me, I was lucky enough to have an incredible surgeon to do that for me and to work with me from, start to finish on that. And I'd been with him for a little while before we started that. So he knew me very well. But it feels like, and I know you feel the pain of this too, is that like the science and the research is just so far behind what patients need, right? Like the medications are just really not there. The treatments, as we said, they're advanced, they're invasive. Is there anything that you've identified besides just the conversation with the patients or working with patients day to day, right? Like you're not going to be able to treat every patient the same. We've already, that's not something that anybody is going to argue, even patients. We know that. But is there something like around the guidelines or around the treatments that maybe you could see changing some of those guidelines, or that like conversations with patients, maybe including patients in these panels to talk about their experiences? Like, do you think that could be beneficial to like the next set of guidelines to really give the people who are studying the disease the opportunity to hear from the people who are living with the disease to say whether or not, like, is this experimental, and the doctors like yourself who are having more conversations with the complicated patients who've been through all of these treatments to really do that. Like, what do you see for the next set of guidelines, really?
I recently went to the dysautonomia meeting last weekend, and it was wonderful because a lot of patients were there. And that's one of the rare meetings that I've seen just a ton of patients there. And I thought it was wonderful because they were included in the discussion. Yeah, I agree. And when you're making guidelines, not a single patient is in the room with the physician. I do not make the guidelines. When we talk about it's not like withholding these advanced therapies, but being very cautious and mindful about it, is that after doing this for a while, like I'm not, I've been attending for 5 years, but I've been a doctor for over a decade. You see where things go wrong, right? When you do, I was a proceduralist for many years, and you see that it's not a benign thing. And so if you're doing something, you better make sure it's the right move. Okay. I know we're talking about a lot of very desperate, very uncomfortable people, but it just hasn't been well studied. And so that's where it comes down to the patient provider discussion. Like, if it's like, do you think this is the right move? Like, after educating someone about it and they say yes, then we find you a way to get that procedure. The hesitancy to widely recommend it is because gastroparesis is so heterogeneous, right? Like not everybody's gastroparesis is the same in the way that their stomach moves or doesn't move, or the pylorus relaxes or doesn't relax. Like everybody's different. And when we study anteroduodenal manometry, which is seeing how the stomach contracts, we realize that everybody's gastroparesis is different, not only in kind of what the muscle tone is, but the nerve conduction to how they got there. Is it after a surgery? Is it diabetic? Is it idiopathic? Right? So everybody's different. So and then when we do studies like G-PACT, and I say we, it isn't me, but when they've done G-PACT studies, it's been a single center. It's been one hospital that did it with not a lot of patients. And it's promising, sure, but there are also people that didn't get better, right? And so it's not benign. I mean, for all intents and purposes, it is quite a safe procedure. And that's fantastic. But we don't know how well it works. We don't know who to do it in. And it's a big deal, right? You can get dumping syndrome afterwards and create a whole new problem that could be quite debilitating when there wasn't one to begin with. So I guess it all, the guidelines come from data and good data. And sometimes we handcuff ourselves. We are so stuck in the mud because we don't have the data, because these trials are tough to pull off. They just are. Not that many people who get, most gastroparesis patients that I have don't need a POA. Most people that I meet have motility disorders where you can treat it with medications or diet alone. So you're talking about a very small, relatively small percentage of people who are visiting a single center who are willing to undergo this procedure. And then you have to study it. And so it's really tough to study. It really goes down to finding your team that I think fight for you and listen to you. And even, when you're going to run into roadblocks, but to understand how to pivot and where to go next. And if they need help, that they know how to, they're willing to call on other people to help them out, and just putting the patient first.
Yeah, no, I couldn't agree with you more. Having the medical team behind you, just people that you trust, that they have your best interest as a patient, at heart, that really is very important. But I want to be mindful of your time too. So thank you so much for, joining me today. I really appreciate you hopping on and having all the information. I know that I've been able to learn quite a bit from you, so I appreciate it, and I think our audience will as well.
Yeah, thank you so much for having me. I'd love to do this again sometime.
Yeah, thank you.